All right, hey guys, I'm Dr. Busti, your faculty and host on This Is Why, a show that helps healthcare professionals transform your medical knowledge from what to why. In my 30 years of experience in nursing, pharmacy, medicine, and as a faculty member, I found that when we understand the why, we can master the how. This means that complex medical decisions and concepts translate into clear, patient-oriented decisions. Now, this topic review is going to be focused on the area or category of evidence-based medicine, which has been around for 30 years, most of my entire career. It's evolved. And since it started back in 1992, and in being introduced as a new paradigm shift in how we train medical professionals, it's been widely accepted as a discipline. And having a firm foundation is important to its integration and application in clinical practice. So this is a series, okay, where we're going to start off talking about what is evidence-based medicine, and it's the reason that is important, the why, is so that we're all on the same page. If you're going to build something that has a foundation, then all the parts must fit together. So please don't ignore and think or assume that you actually understand all these parts. I did an entire master's degree on evidence-based healthcare, and I can tell you, I came in with a lot of assumptions and presumptions that I was actually wrong on, okay? So let's jump into the very basic initial step of what is evidence-based medicine. We also need to consider what is it not, okay? When we talk about evidence-based medicine, I want to also begin to introduce to you other EBM terminology. I call it evidence-based XYZ. Things like evidence-based healthcare, evidence-based practice, evidence-based practitioner, evidence-based expert. My goodness. I mean, how are those different? But also, more importantly, what I struggled with when I was learning this discipline the proper way is, how do those things fit together, right? Are they the same things, or where are they different, and how do I fit into that framework, okay? Now, we're going to go back to the original paper that started it all. This was the publication in JAMA 1992 by the EBM Working Group. Okay, made up of a large number of individuals throughout the United States, but also Canada, okay, and other places. But you can see that first sentence that was really important. They used the terminology, a new paradigm for medical practice is emerging. And it's really this idea, especially in an introduction here, right, that we're moving away from this framework of, I told you something and therefore it must be true, right? The early stages of medical education and training were mentor initiated, right? Residency training, a lot of times you went to the expert and you learned, they taught you what they knew. Now, some of that was correct, but some of that was wrong. And so what has evolved over time is this shift away from assuming that just because I have done and take care of patients doesn't necessarily mean it's the right thing for the patient or that's the best treatment for the patient. We should be willing in this process to ask the question, is this the right thing to do? Do we have evidence that supports that? And if we don't, that might exist and that might be okay. Then we have to rely on our clinical expertise because that is the reality. Okay, nothing wrong with that. Now, most people have seen the Venn diagram at some point in their career. If those of you that are in your earlier stages of training, you might just be introduced to this for the first time. But the Venn diagram represents three major components that are most common for the topic of evidence-based medicine. You've got best evidence, right? You've got the clinical experience or the expertise of the provider themselves. And then there's these patient-specific factors. And when all of those three things come together in appropriate balance, you have EBM here in the middle. Okay, you see there's overlap. That means they don't exist in isolation. But we're going to take a moment, since we're talking about what is EBM, and let's go through the basic components at a high level. In the other parts of this series, I will break down these in more detail so that your knowledge is being built upon, so that you get the framework, the core concepts, but you begin to understand why it matters and how you apply it clinically. All right, so when most people think of evidence-based medicine, or they use the word EBM, this is where their lens is. This is where they focus. It's the best evidence, right? And that sometimes is to our disadvantage in even the word evidence-based medicine, because it gives the focus on the literature itself, the data. But remember, it's not in isolation, okay? But this is where, when you go to courses or take classes like maybe this one, or you're watching this and you're learning this, this is where most people stay. And I think that's actually to our disadvantage. And I'm going to break that down and make sure you don't do that, because it's not right in the way we approach patient care. Okay, the second is clinical expertise. What is that? Well, that's going to school, nursing school, pharmacy school, medical school. It also includes post-doctoral or degree training, postdoctoral training, in most common cases, residencies, right, for those professions that have them. It can be advanced certification programs. Things like in nursing, there's, TNCC and other things like that, and certainly things like ACLS, PALS that we all do. Those are important other components that build into our experience. So it's reading books, going to class, that hands-on training that we've all done in our clerkships and preceptorships and rotations and things like that. But then there's also the patient-specific factors and preferences. Okay? This may need to include their socioeconomic status, whether they have actual insurance. What type of insurance do they have? Are they going to have to go through a prior authorization process? Are they against shots, or do they only take pills? I mean, all of these things are patient-specific factors that may guide us in implementing the right drug or treatment for our patient and that scenario, whether it's an acute care situation or a chronic care situation. It's not the same all the time. Okay? There's other things that you might need to consider. Cultural, right? Those religious reasons. There are some groups that can't take certain medications. You need to understand that so that you can treat all of your patients and consider shared decision making so that you can educate them about their options, factor in their preferences, and then apply the best treatment for them. Okay? Now, coming back full circle here, you see that in this Venn diagram, these circles are all the same size. Again, in evidence-based medicine conversations, we tend to, if you were to say it's lopsided, I would make the evidence circle significantly bigger and the other two sort of get ignored, right? They're assumed, and very rarely do we stop and think about what the patient actually wants, right? We know everything. No, talk to your patient, ask them, involve them. Again, that shared decision making. And so this is where it seems to be lopsided and many times is not being applied in the original context that it was designed as in the evidence-based working group in that JAMA article. Now, when we talk about best available evidence, what are we doing? Well, there's something called the 5 A's, okay? And I'll walk you through them. It's kind of like a stair-step approach because they build on each other, right? So step 1 here is ask a proper clinical question. But in the context of this, it's a individual patient-specific question. Singular, not plural. Now, you might say, well, wait a minute, Dr. Busti, can you not apply a clinical question to a group of people? Well, certainly you can. Nothing wrong with doing that, especially if you're a specialist who sees patients that look similar. That would be appropriate. But even inside that, There are still patient-specific factors, pharmacogenetics and genomics. It may be other comorbidities that may make one treatment a contraindication. It may be cost, right? So even inside there, you still may have to adjust the treatments that you do, even if your patient population looks very, very similar to each other. Okay, next is step 2, you got to go acquire the information. You know what the question is. Now you got to go find where is that, what data do I have? And this is where searching out the literature and your primary, secondary, and tertiary sources become very relevant. Once you acquire that evidence, you got to now appraise it. We use the terminology critical appraisal. And unfortunately, that word critical many times comes across as negative because you're being critical. Like, I'm going to find what's wrong with this information. These researchers couldn't have possibly done good research. I'm going to find out what's wrong with it. I mean, we have this sort of negative attitude. I've been in so many journal clubs throughout my career, and it seems to be that we focus in sometimes too much on the negative and picking things apart. The reality is there's no perfect study. There's no perfect evidence. Right? Now we try to make it more real world, right? Pragmatic, mixed models, all these things that are trying to improve the relevance and application in real world clinical practice. But the reality is it's not perfect. So we have to appraise it, looking at its risk for bias, trying to discern, is this data valid? Is it real? Because if it's real, then I need to externally apply it. And does it apply to my patient? Well, it goes back to your question. Right? And then so the last, or not second to last step here in step 4 is apply it. So you found what you think is the best available evidence. You think you have the right information. Now you go back. Does it apply to your clinical expertise? Does it factor in the patient-specific issues and preferences? Then you apply it. But the last step, step 5, the last of the 5 A's, is assess. And it's down here. And a lot of people actually, I was surprised very early on when I was studying this that doesn't happen. What does that mean? It's basically doing a research project of your own individual medical decisions every day. All right? You're taking care of patients. Are you assessing how you're doing? Or do you just assume that everything that you do is correct? I mean, I get a lot of patients who arrive at the emergency department with problems associated with treatments initiated in the outpatient environment. I'm not dogging on outpatient providers. I mean, we make the same potential mistakes as well, right? But the reality is if that person doesn't see that or doesn't know about it, they're oblivious to the fact that their decision was actually a wrong decision for the patient. I just happen to be the one now seeing them. So there needs to be that continuity or you wouldn't know. So assessing your own patient decisions becomes important. Does that evidence apply to your patient population the way that evidence is suggesting to you that it would, right? Well, that takes effort. And I'll just be honest with you. I'm pretty busy, right? Stopping to do an assessment and look at my own data and my own metrics and all this stuff. That takes time. Doing callbacks, checking in with patients. We would do that during residency. It was required of us to call back so many patients that we had seen over a period of time to make sure that those decisions that we made actually were the right decisions for the patient. If not, then what could we learn from that? There's a significant amount of value at that spot. But many times it gets dismissed because we're too busy. Or sometimes we don't have the data to be able to do it. But most, like I said, where people anchor in evidence-based medicine is in this particular circle right here, and they don't give the weight to these two appropriately. But the Venn diagram purposely has 3 circles that are all the same size. All right, you've heard me talk about and introduce some evidence-based, again, XYZ terminology. You know, so are we on the same page, right? So there's terms like, again, evidence-based healthcare, evidence-based medicine, evidence-based practice. Some people even use evidence-based clinical practice, right? Evidence-based practitioners, evidence-based experts. You know, so what is EBM not, right? Well, again, in its original context, going back to the original papers, it does not represent the day-to-day practice of medicine as a whole. I know it sounds like it should, and we think actually that it probably is, but really it's about those 5 A's because you're addressing that patient-specific situation. It's a clinical question and scenario, okay? But just because you know how to do the 5 steps of EBM or follow the 5 A's and can quote them and you know how to critique a paper doesn't mean that your practice is evidence-based always. It also doesn't mean that you're an evidence-based practitioner or an expert. So what are those things, right? How do they fit together? So I want you to just follow along with me. Again, there's no published framework for this. I developed it because, quite honestly, when I was studying this at Oxford, I was frustrated that the literature and these experts in the field didn't take the time to actually think through, and I don't mean this negatively or arrogantly, they just didn't. I don't know why, but they chose not to define it. I actually had some colleagues who challenged me on that statement a little bit and said, well, can you even define EBM? I'm like, well then, I think so, because guess what? They're trying to. Their books actually have sections for the definition. They actually do try to define it. So there's this effort that we seem to want to define it because anything that we define obviously creates a framework that we can then operate in. So I think we do. All right, follow me here, guys. All right, so think of evidence-based healthcare as this umbrella, right? I mean, healthcare, the medical system as a whole. I mean, that's hospitals, that's outpatient clinics, day surgery environments, it's the pharmacy, it's social services, it's the whole thing, right? It's not just your area of practice. It encompasses all of us as a healthcare team, right? Which is what it should. So think of it as the umbrella, overarching thing. Well, we've been talking mostly at this point about EBM over here, where there's this application of the process of evidence-based medicine for an individual patient scenario, right? So clinician to patient, okay? But then there's also this evidence-based practice. So let's stop and talk a little bit about what is evidence-based health care. And I'm just giving you an example. Again, I'm not saying that these are good definitions. I'm not even advocating for them. I quite honestly don't like them. Obviously, I just gave you my bias. I think it causes more confusion. I don't see the purpose of it, and I can't find the difference very easily in them. But when you look in books that are out there, and these are reputable books that are used by educators like myself who teach this course and other places, lecture on this topic, do clinical research over time, this is the kind of stuff that makes it difficult, right? So I'll zoom in a little bit here and you can see this is the conscientious, explicit, and judicious use of the current best of evidence in making decisions about individual patients. Well, that sounds like the definition almost of EBM. Evidence-based clinical practice, so they introduced another term here. Requires integration of individual clinical expertise, patient preferences with best available external evidence from systematic research and considering available resources. Sorry, I mean, I hope you see what I'm talking about here. It sounds good, but it sounds like a lot of salad words to me. Okay, I don't know really what that means. So I thought, well, in my head and the way I was trained at Oxford, to think of it as a bigger evidence-based healthcare as the entire system, and then we're individually applying these in various environments and through guidelines and through individual patient care decisions, and collectively, that's what evidence-based healthcare is. But what makes something a practice? Well, now think of it as, I'm a clinician. I will see easily, between 25 and 35 patients, depending on the emergency department, the day, what's going on, where I'm at. I'll see that many patients, right? So that's my practice. But I'm seeing multiple patients, and in my practice, I'm not seeing the same patient. I've got pediatrics to middle-aged adults to geriatrics, and I've got things in there for you shouldn't be here because this is a chronic medical problem. You should be seeing your primary care provider for a medication refill to gunshot wound, right? I mean, it's the extremes. Okay, so my patient in my clinical practice looks very different. So I'm making a lot of individual patient decisions throughout the day that vary from the one patient to the next. That's different than maybe say a cardiologist who's an electrophysiologist. Well, that provider and that area of clinical practice is very focused. You got a cardiac dysrhythmia, and you map it, and sometimes you're going to ablate it, and those patients start to look and seem similar, where there's some consistency, right? But again, that's an individual practice, right? So if we were to, again, look at the definition, because these definitions have been published, it says here, in clinical practice in which the patient management decisions, okay, that's plural, are consistent with the principles of evidence-based health care. So it's kind of falling underneath, which is why I put it underneath in my framework. And this means these decisions are consistent with the best available evidence about benefits and downsides of alternative management strategies. So you're now managing patients. That's different than the process of an individual patient care scenario, right? And then at the end of the day, we are going to consider their patient-specific values and interests. All right, now seeing these two come together, again, those are the bigger umbrella. We're just kind of starting to drill down inside of that. So then what is this thing about being a practitioner who's evidence-based and someone who's an expert? Like, how do you differentiate those people? Well, again, these terms have been defined. I've put them here for you. But really what it comes down to is you take a practitioner, which is this definition here. These are people, right? They're licensed practicing clinicians. They know where to find information. They know how to read summaries of evidence-based information. And they basically are applying it, but they're not doing the individual critical analysis of the papers necessarily. They're just taking somebody else's work or summaries and now applying it to their patients. So guidelines, some systematic reviews, summaries of evidence-based information. Okay? Now the expert is going that step further. They're the ones who, yes, they know how to do that. They can go find the right information. They know these sources that are out there, but they also are involved in the 5 A's themselves. They can actually articulate to you or to another provider or hopefully to the patient why they're doing what they're doing. That's an expert. You don't just have somebody else feed it to you. You're the one discerning it. And that's what lifelong learning, is supposed to really be about. This idea that we will continue to maintain our knowledge by reading the literature. That's the assumption. That's why CE is required. Because things evolve. But if you're always fed that information, you don't necessarily become an expert, right? I'm not saying that's wrong. I mean, people are busy. I get it. And so who are typically those experts? Well, many of them tend to be in faculty or academic environments or positions because they have some degree, I've been in faculty positions, and I hate to say this statement, but some degree of protection, right? I.e., you're expected to read the literature. You're supposed to be debating these topics. You might be the one doing the clinical research yourself, right? Yeah, I've been in faculty positions in nursing, pharmacy, and medicine, and I can tell you get pulled all over the place. You're on committees. You got a clinical practice to maintain. You got students, residents. You're supposed to publish. You're supposed to do papers. I mean, it's difficult to manage an academic position. I'm not saying it has its pros and cons, just like everything else. But the reality is many of those tend to be people from academic medical centers because they're engaged in that in a more in-depth process and have a little bit more of that time and engagement opportunities to debate these topics. But that's kind of the difference, if you will. So you're narrowing in as you go down in this framework. But at the end of the day, when all of these things are being done, I'm doing my part. I'm doing it not just for individual patients, but all my patients. And I am doing that, and other healthcare providers are doing that for their individual patients and for their group of their patients underneath this umbrella of the healthcare system, and we all do that, then that's where patient outcomes are not only maximized but improved, okay? All right, so what are some observations that we can make about these evidence-based terms? Well, one is, I believe they're purposeful or intentional. I think that the terminology could be defined better to be clearer than what I just presented to you. And again, I'm not trying to be negative or, condescending or anything like that. That's not what I'm doing here. But I think it needs to be better defined because I was confused. I would scratch my head reading one book over the next and seeing inconsistent definitions, right? But here's where they are consistent. They're consistent on the idea that we are using the best available evidence. Okay, again, I will break that down in future topics, but it's the best available. And it also keeps coming back to this idea of being patient-oriented or centered, okay? So that's the overview of EBM. Now, I do have, and I'm going to follow this topic with a deep dive. For those of you that are members of This Is Why, which you can sign up for free. But what we've covered here today, right now, is what is EBM? What are the components of EBM? And then inside of that evidence, what are the 5 A's when doing that? Remember, you got ask, acquire, appraise, apply, and then do your own assessment. Do your own assessment. But when you do that and you take the Venn diagram and each of these circles is balanced appropriately in the same degree of influence, you get the intended goal and outcome of evidence-based medicine. Now, guys, I'm Dr. Busti, and this is why we're here to help medical professionals understand why, so that you can master the how. How do you go about doing EBM and becoming not just a evidence-based practitioner, but an evidence-based expert, so that your clinical practice is evidence-based, right? That's the how. So when you're able to do that, you're not just practicing medicine, nursing, or pharmacy, you're transforming it, okay? So our members at This Is Why, you can now stay on and jump into the deep dive. And I'm going to just take you through some other topic areas and some additional points on this particular, for those that want to go a little deeper on the framework of EBM. But if you're not a subscriber or a member of This Is Why, please go to the website and sign up for free. It's free, right? You can get access to not only deep dive content that I provide you, but there's also things like downloadable images, tables that you can have access to on certain topics that we give people, right? Handouts. You'll be invited to live events, an opportunity to ask live Q&A sort of environment so that we can learn from each other and engage, right? There's also discounts for some of our partner programs that you can get. So check it out. And I hope that you found this to be useful as a framework and a foundation on the topic of EBM.